Assalamu alaikum. This is the second part of the previous lectures of filarial worms, and I made it on 2 lectures because if one lecture it is very heavy for you. Now we'll have Mansonella Ozzardi, Mansonella Ozzardi and Mansonella perstans and Mansonella streptocerca are very important filarial worms, but they are present outside Egypt. We don't have any cases of these filarial worms in our country, but we must know about them because they may appear in our country in tourists or in other people coming to Egypt. The first one is Mansonella Ozzardi, only present in Latin and South America. Adults inhabit the mesentery and intestinal fat in the omentum or in the mesentery. The microfilari are unsheathed, present in blood and in blood capillaries of subcutaneous tissues. They don't cause any pathology, but they are transmitted by culicoides and simulium flies, and the infection is asymptomatic, but allergic manifestations, fever, eosinophilia, and inguinal lymphadenopathy can occur. The diagnosis is by blood film, finding microfilari and high eosinophilia. Treatment is by diethyl carbamazine or ivermectin, either of them. Here is the unsheathed microfilaria with the tail devoid of nuclei like that of Wuchereria bancrofti, but it doesn't have a sheath. The second one is Mansonella streptocerca. Mansonella streptocerca is present only in tropical West Africa in both humans and monkeys. The microfilari are unsheathed also, mainly in skin, but also may be present in blood. The tail is bent like shepherd's crook، يعني عاملة كده زي العكاز المتني اللي بيد كده بيمسكها راعي الغنم، عشان كده سموها shepherd's crook, and it is filled with nuclei. Human infection is characterized by pruritus, hypopigmented macules, and inguinal lymphadenopathy. Vectors are culicoides flies. These are small blood-sucking flies اللي احنا بنقول عليهم الهاموش، بس الهاموش اللي عندنا doesn't infect man by any disease. After treatment with diethyl carbamazine, adults can form subcutaneous papules or nodules 5 to 15 millimeter in diameter. This is the microfilaria of Mansonella streptocerca with the coiled posterior end. The third type is Mansonella perstans. Mansonella perstans is infection in man and monkeys in all tropical Africa and tropical America. يعني قبل كده كان في واحدة في تروبيكال أمريكا بس اللي هي الأوزاردي. بعد كده الستريبتوسيركا كانت موجودة في تروبيكال أفريكا أونلي. دي بقى موجودة في الاتنين، في تروبيكال أفريكا tropical America, and it is transmitted by culicoides only, not with simulium like Mansonella Ozzardi. The adults live in deep connective tissues. Unsheathed microfilari are in peripheral blood, and there is no periodicity. The tail end is full of nuclei، تبقى كده زي اللولوة مش زي البوتشيريريا اللي هي مانسونيلا اوزاردي. The last pair of nuclei is slightly separated, but it is full of nuclei till the posterior end. This is the microfilaria of Mansonella perstans. Mansonella perstans symptoms vary. There is calabar-like swelling, pruritus, urticaria, fever, headache, and there may be bone pains, arthritis, and lymphadenitis. There is also in Uganda, they can cause Kampala or Ugandan eye worm with bulging of the eye and periorbital inflammatory reaction around the adult worms which are present in the periorbital fat. Treatment is by diethylcarbamazine is ineffective. A combination of mebendazole and levamisole HCl is effective, and also ivermectin is effective for treatment of this worm. Now we come to the most dangerous African worm, Onchocerca volvulus. Onchocerca volvulus is present in tropical Africa, tropical America, South Saudi Arabia, and Yemen, transmitted by simulium or black flies. Both adults and microfilari are subcutaneous. The disease is endemic around waterfalls and fast rivers due to the habits of the vector which breeds in these places. Microfilari undergo the usual cycle in the thoracic muscles of simulium and grow into infective larvae to enter a new host through the bite wound. In case of Onchocerca volvulus, the simulium cuts through the skin, makes a small pool of blood and sucks what he needs and leaves the rest. The third stage larvae pass with this blood and come in the wide opening of the bite wound. This ensures infection with Onchocerca volvulus more than the other types of filari. In the new host, the infective larvae settle in couples or in groups encapsulated in skin nodules, what we call onchocercoma, formed by the host reaction around them within a year after infection. This is a diagram of the life cycle of Onchocerca volvulus. We can see here the simulium bites and takes the microfilari, which change into first stage larva, second stage, third stage larva, and the simulium again drops the third stage larva on the human skin. Then it penetrates through the bite wound and lives in the superficial layers of subcutaneous tissue. Then it forms the adult male and female. The female is very short and the female is very long. And the adults produce unsheathed microfilari, look like those of Buchereria bancrofti, but they are limited to the subcutaneous tissue only. Nodules are about 1 to 3 centimeters in size. They are mainly present on bony prominences, or they can be seen on bony prominences like the tibia, like the scapula, like the temporal part of the head, also in the iliac crest or on the ribs. They form on trunk, iliac crest, and lower limbs in Africa, while in America they form on the scalp, shoulders, and upper trunk. This is an African patient having the onchocercoma here. Also, this one has several onchocercomata, one here and one here and one on the iliac crest. This one also have the onchocercoma on iliac crest. Adult females are about 40 to 50 centimeter by half a centimeter, while males are only 5 centimeter long. Microfilari are unsheathed. The tail end is free of nuclei like those of Wuchereria bancrofti. They are found in the dermis and in connective tissues. They can be found also in urine, especially after giving diethyl carbamazine. Adults in nodules don't cause any other symptoms except the onchocercoma, but the main pathology is caused by those microfilari in the skin and the skin adnexum. As I said, the main pathology is from the microfilari. Reaction around them causes tissue damage, loss of skin elasticity, and infiltration by inflammatory cells. This occurs in the skin and in the eyes. The continuation of skin in the eyes is mainly the cornea and anterior chamber, also the choroid and retina posteriorly, and the optic nerve. So it affects the eye in many places. Skin symptoms are in Latin Americas have the inflammatory skin reaction in the upper part of the body. This is called onchodermatitis, malmurado, or erysipelas de la costa. Loss of elasticity causes premature senility or leonine facies. In Africans, it affects the back, lower trunk, and lower limbs. There is thickening of skin and areas of depigmentation, what they call leopard skin, because in the dark skin there are pale spots like that of leopard أو زي جلد النمر أو جلد الفهد. Loss of elasticity of the lower abdomen causes skin to form what we call apron changes, apron-like changes. This is here some pictures of onchodermatitis. We can see here, this is a Latin American child with thickening and disfiguration of the skin on his cheek, what we call erysipelas de la costa or malmurado. This one, this picture shows the depigmentation of the skin, what they call leopard skin. Also, it is present here on the back of this patient and in one arm, as we can see here. This is what we call onchodermatitis. dermatitis. As we said before, the affection of lower abdominal skin causes folding of the skin, or they call it hanging groin or apron-like folding, because the inguinal lymph nodes pull the skin down, so the skin is redundant, having hanging groin or apron-like folding of the skin. Elephantiasis of scrotum can also occur due to folding and obliteration of lymphatics. Also, inguinal and femoral hernias are common to occur. In Yemen, the manifestations are localized in the lower limbs, and microfilari don't appear elsewhere. It may be localized in one limb as dark discoloration, they call it soda, inflammation and swelling and enlargement of regional lymph nodes, and the microfilari are few, so it is considered hyperreaction or hyperinfection to hyperimmune reaction, to onchocerca. This is the picture of Onchocerciasis in Yemen, what we call soda. You can see the difference between the normal skin and the affected skin. Here is the hanging groin deformity with inguinal lymph nodes taking the skin down like this. Ocular manifestations, which is the most important issue in this lecture. There is in the cornea, there is punctate keratitis, means that every microfilaria in the cornea is surrounded by inflammatory reaction causing whitish discoloration of the cornea, so they call it punctate keratitis around microfilari in the cornea, and it may coalesce and making corneal opacity. Also, there is limbal inflammation and pterygium formation. Microfilari in the anterior chamber and iris can cause iridocyclitis. Fibrosis cause fixed or distorted pupil and may cause also what we call it can cause raising of the ocular tension, or what we call المية الزرقاء. I can't remember now what is called in this case. Extension of microfilari to the choroids and retina causes choroidoretinitis or retinochoroiditis, whatever it is said, and optic neuritis. The previous manifestations can lead to what is known as riverine blindness. It occurs in African more than in American disease. Riverine blindness can affect villages, whole villages in Africa around the River Nile resources, or in other rivers in Africa, around the huge lakes in Africa, and also in the waterfalls there. So they call it riverine blindness. Here is a blind man, bilateral affection of the eyes, and it is a good picture for the disease. Diagnosis of onchocerciasis is by skin snip because the microfilari are present in the dermis, in the subcutaneous tissue, so by excision of small portion of skin raised on a needle, then putting this portion on a slide with a drop of saline, microfilari can appear moving out below the skin margin. Also, Mazzotti test can be used. This is administration of low dose 50 milligram of diethyl carbamazine, and this can irritate the microfilari to come out from their places and fill the skin hole, and we can take a skin snip. Surely we can find microfilari, but this is very dangerous because it provokes ocular manifestations in the people who don't suffer from ocular manifestations. Urine examination sometimes may show microfilari when there is elephantiasis of scrotum. Also, excision of the nodules and their examination is diagnostic and therapeutic at the same time because we can get rid of the source of microfilari, which is the adult female. Here is a picture of the skin snip. You see here, the doctor pinches a small portion of skin between his fingers and takes by a small scissor. Here he takes a small snip. Also here it can be done by the scalpel and the needle. And this is the microfilaria coming out from the skin on a slide and can be seen even without staining or without fixation. This is a cross-section of onchocercoma with the adult coiled on itself. Here is a more magnification of the previous picture. We magnified this part here, and we can see the uteri inside the female full of microfilari. Treatment: diethyl carbamazine is microfilaricidal, but its side effects are intense pruritus and ocular involvement. This also makes the people refrain from taking the treatment because of their inconvenience. Also, ivermectin is the drug of choice with less side effects. Adults are not affected by previous drugs, and surgical removal is usually done. Tropical pulmonary eosinophilia as an issue. It is a common syndrome where there is eosinophilic lung disease, or TPE, is characterized by marked eosinophilia, cough, wheezing, scanty sputum. Chest X-ray shows patchy infiltrations. Eosinophilic count may exceed 50%, and there is high immunoglobulin E. There is high titers of antifilarial antibodies. Microfilari are not found in blood but may be found in lung biopsy. Also, it is considered an exaggerated immune reaction of some people in endemic areas. The case improves with antifilarial treatment. These parameters must be present all to diagnose the case as tropical pulmonary eosinophilia, especially that the case improves with anti-filarial treatment, and there is high titer of anti-filarial antibodies. Some consider that it is caused by dirofilaria infection, which is the dog filaria, as the dog filaria doesn't appear in circulation, but it is present in the body, eliciting allergic reaction. We come to the end of our lecture by discussing the non-filarial elephantiasis. Non-filarial elephantiasis is elephantiasis of non-filarial origin، يعني مش السبب فيها أي نوع من الفيلاريال worms. It is present in Eastern and Central Africa in the Nile Basin أو في دول حوض النيل, especially in Ethiopia. It occurs in barefooted persons, الناس اللي بتمشي حافيين, ودول usually are present in African people in Ethiopia and in the Nile Basin. It begins distally in the feet, ascends upwards, and rarely extends above the knee. It is caused by absorption of metal salts from the ground through the abrasions in the feet, and the crystals of silicate, iron, and aluminum salts are found in the hypertrophied lymphatics, and this is not treated by any means. And also now I can tell you thank you for listening and goodbye.